Today's talk, first of all, I'd like to thank Ann and the organizers, Nutrition and Margaret Stallings, for really putting on a great program, and we hope it continues. I have to say that perhaps, unfortunately, there will be some repetition, but repetition is the best way to learn. I actually have a question that is at least perhaps not directly related to the topic of the discussion, but lets us assess, and you should hire, Mark, anybody who gets this right. It lets us assess our awareness of our environment. Does anyone know what at least almost all of the rooms, the meeting rooms, are named after? I had an epiphany walking down the hallway. One of them is not named after the girl who's having the bat mitzvah, by the way. It's the only one I don't quite know is this room, Tyler's room. Everything else is named after an art or museum somewhere. Guggenheim, the Hara Museum, all of them. So nobody got it. I guess can't hire anybody from this crop, huh? Well, today I'm going to be talking about nutrition and liver disease, and I'm not going to be talking too much about specific disease entities, but I will be talking about the pathophysiology, the physiology and pathophysiology that occurs with liver disease, and then I'll be talking a little bit about monitoring, and you'll see some of the same slides you've seen before, and also talk about some of the treatments that we use for cholestatic liver disease. So I think you have to note that malnutrition is an observed phenomenon. We know this intuitively when we see children with a big belly and no arms and legs. But most of the studies have really been performed on adults. There are some studies that are pediatric, but we have to extrapolate. I think when we see our pediatric patients in large part. The causes of malnutrition include iatrogenic causes, such as unpalatable salt and protein restricted diets. And I'm going to make a plea that we not treat these patients and restrict protein or salt excessively. But in addition, there are some data suggesting that there's inadequate leptin catabolism, much of leptin catabolism, and I think Rohit can address this more in greater detail, but a lot of leptin catabolism occurs in the liver. And if there's inadequate catabolism, you have increased circulating leptin and an anorectic phenomenon. In addition, zinc deficiency is extraordinarily common, and we know that because of hypoplasia of lingual papillae with zinc deficiency, one may have dysgeusia or ageusia. Even before Ginés and Arroyo's study, C.J. McLean from Louisville, when he was working in Minnesota with Larry Zeev, showed that zinc deficiency was quite prevalent. They actually, in adults, they actually looked specifically at dark adaptation, and you remember zinc is an important cofactor for the rods and the cones of the eye and the proper ocular physiology. And I bet nobody knows Larry Zeev, right? He was about 25, maybe Rob may be old enough, and but most people, yeah. But I mean, he was really one of the most famous hepatologists around in the 1970s, when I was in training, and nobody knows him anymore. He even has a syndrome named after him. When alcoholics become abstemious, paradoxically their liver function deteriorates and they get a hemolytic anemia, and a small percentage of them, and that's called Zeev's syndrome. So it's thought to be caused by delipidization of the liver. But there's also substantial insulin resistance among cirrhotic patients. There's no question that insulin resistance has been shown in adult study after adult study. And then a cytokine excess also occurs. And we have heard, at least in IBD, that cytokine excess, when you have an excess of the inflammatory cytokines, produces an anorectic response. What other iatrogenic processes take place that interfere with nutrition? Well, dietary sodium and protein restriction, I mentioned. Large volume paracenteses. You're losing a lot of protein when you do a large volume paracentesis. Fluid restriction will result in malnutrition, and oftentimes if you over fluid restrict, you'll predispose to hyperaldosteronism, and when you're salt and fluid restricted and are hyperaldosteronemic, you will grow poorly. And some of our medications, for example, neomycin causes an enteropathy. If you have someone on neomycin or any oral aminoglycoside long term, you put the patient at risk for subtotal villous atrophy. Lactulose, which can produce chronic diarrhea, and the antibiotics that are sometimes used can alter the flora and result in reduction of important flora-derived products such as vitamin K. Overuse of diuretics will do the same thing, and I don't know if anybody still uses cholestyramine. Does anybody still use cholestyramine? I don't think we use it occasionally, but we have to be very cautious and use very, very small doses, because you may, if a patient we tend to prefer things such as rifampin for the treatment of pruritus, because cholestyramine does induce a fat-soluble vitamin malabsorption if it's used in high enough quantities. Beyond inadequate intake, you have malabsorption and maldigestion. Cholestasis in and of itself can produce malabsorption. A protein-losing enteropathy can be associated with portal hypertension. And then in some liver diseases, some of our cholestatic liver diseases, we have associated pancreatic insufficiency. For example, patients with PFIC 1 generally can have recurrent pancreatitis and can be pancreatic insufficient after they've had several bouts of recurrent pancreatitis. In Alagille syndrome, you can see an idiopathic pancreatic insufficiency, which Dave Piccoli showed years ago. In addition, you can have recurrent pancreatitis simply from portal hypertension, or you can have pancreatic fibrosis from long-standing portal hypertension because there's an increased venous pressure within the pancreas. This was a really excellent study that was published, boy, that's a long time ago, 1988. I guess I still had hair back then. A group from Israel, Barrett and his colleagues, created a theory vela loop in dogs. That's just exteriorizing a loop of bowel. And then they did superior mesenteric artery perfusion of saline and progressively increased quantities of primary bile acids. And what they found that at 8 micromolar, which is very easily achievable in severe cholestasis, you had disturbed transport of water, sodium, and amino acids. And at 22, there was very severe sodium and water transport abnormalities and net secretion rather than absorption. Let's turn back to glucose homeostasis in liver disease. When we see insulin resistance, that can generally occur in advanced cirrhosis. In mild or acute liver disease, that tends not to be present. So if you have someone with chronic liver disease, you may see hyperglycemia and hyperinsulinemia, which, one thing that Rob didn't mention was that hypertriglyceridemia and fatty liver can be a direct result of hyperinsulinemia, even with euglycemic blood sugars. The starvation pattern, which you heard Praveen so elegantly describe, it can be accelerated in chronic liver disease. These are adult studies, but we have every reason to believe that they occur, that the same phenomenon occurs in children. You see gluconeogenesis much more rapidly, and as you know the starvation response, but generally within hours to a day, you start to see ketogenesis for gluconeogenesis. And remember, gluconeogenesis requires not only conversion of protein to glucose, but also use of the glycerol from triglycerides to provide a substrate for glucose generation. And then protein catabolism gets accelerated. This is basically a diagrammatic representation of that. The liver, as you can see, is central. The liver lets you live, as I said. The liver is probably the seat of not only intermediary metabolism, but the seat of the soul. We know that initially liver glycogen stores are depleted. Many of these patients have depleted stores to begin with, and then ketogenesis occurs, and then you start using protein and lose lean body mass. And this process is so accelerated that it is recommended that patients be fed frequently during the daytime, and perhaps pediatric patients should be fed at night. Protein metabolism is affected as well. Protein stores in adults have been shown to be depleted. You really know that these patients have decreased somatic protein stores when you look at their mid-arm circumference. Adult patients have increased proteolysis in addition, and you can't suppress it by feeding. And the branched-chain amino acids, in some studies, this is not Ron Sokol, this is Etienne Sokal from France, or from Belgium, who suggested that protein sparing can take place with branched-chain amino acids. But most of the adult studies that have looked at long-term outcomes in patients who've gotten branched-chain amino acids have shown that really it has not affected mortality or outcomes or complications or need for transplantation. The branched chains can function as ammonia receptors, and they can function to improve encephalopathy transiently, but the cost-benefit ratio may not be worth it. I won't go through these because you've heard them at least twice, maybe 3 times already. The Harris-Benedict equation, I will say, only is important for adults, and most adult nutritionists use the Harris-Benedict equation, but it's far less precise in pediatrics, and we use a lot of indirect calorimetry. And I think Ruba had asked Praveen about, and I think Val showed this, that the respiratory quotient is related to whether you're using fat for energy. If it's below 0.7, you're using fat. And of course, it also indicates that if you're above 0.1, you're using carbohydrate. And Val showed sensitivity and specificity. And, you know, by and large, it's pretty sensitive and specific. So we do a lot of metabolic carts in our patients. Well, the high-risk patient for hypermetabolism tends to have worse outcomes. There is only 62% 1-year and 54% 5-year survival in adults who have a measured resting energy expenditure that's 120% of the calculated REE. But a much better survival 88% at 1 year, and 88% at 5 years if it's 100 to 100. Or I'm sorry, if it's about 100% of the calculated REE. Well, what about obesity and liver disease? And I would have to defer to Rohit for a detailed discussion of this, but obesity does occur, and it can occur in both pediatric and adult patients. And we know that what happens when you're obese is that you have a much higher chance of complications if you undergo a liver transplant. A very, very high incidence of wound dehiscence and multiple organ failure, according to the Sawyer study. So how should we evaluate our patients with liver disease? You're going to see some of the same slides you saw before: indirect calorimetry, biochemical evaluation, anthropometry, and histology and radiology. Except I have better pictures of indirect calorimetry. Is this one going to work? I doubt it. This is what we usually see. The respiratory therapists hate me because I'll order these metabolic carts, and they'll say the child didn't sit still for a minute. So I still go ahead and order them, but I recognize that there are some caveats to the use of indirect calorimetry. And then there's whole body calorimetry. And what can we learn from it? Well, we can determine the respiratory quotient, and we can look at the overall resting energy expenditure. So how do we estimate body composition? Well, I always like the one where you look at body fluid volume, you look at isotope dilution. You can put a patient into a bath and see how much water they displace. That's a neat one. Weight on land and weight submerged. As you know, patients who have massive ascites, the ascites disappears if you submerge them in water for a long period of time. And we can use the other markers for anthropometry that have been discussed. So what are the caveats? Well, it's highly unremarkable in people with ascites. BMI is highly unremarkable in people with ascites or edema. There are imaging techniques, and I won't go into them in great detail. We still use DEXA, and we do not use the computerized tomography scans and the three-dimensional scans. And then we can do tests of intestinal function. We can actually look at breath hydrogen generation to see if a patient's bacterially overgrown. And there are some data suggesting that bacterial overgrowth is extraordinarily common in cirrhotic patients, even those who don't have overt GI disease. We can look at fecal fats in our cholestatic patients. We can measure D-xylose and do nitrogen balance, all very difficult. Fecal elastase is a good way to assess pancreatic function if you don't have massive diarrhea. If you have massive diarrhea, the diarrheal stool will dilute out the elastase, so it's far less reliable in someone with very watery stools. And what about histology? I think we should never forget that gluten enteropathy is very commonly associated with, quote, cryptogenic cirrhosis in adolescents and children. It's something that we should very, very commonly screen for in this group of patients. The mechanism is not fully understood. It is autoimmune. Some of these patients will have autoimmune markers that suggest type 1 autoimmune hepatitis. Others have suggestion of type 2 autoimmune hepatitis, but there are others who have no markers at all, and it seems to be autoimmune liver disease. We can do small bowel series, and we can look at gastric capacity and emptying time. Don't forget that patients who have massive visceromegaly may have a reduced gastric capacity because of simple mechanical compression. And if we've had a patient who's undergone a RULM, it's not uncommon to see bacterial overgrowth in a long RULM that doesn't empty well. Whoops. Ooh. That's not right. There we go. Biochemical markers. what about these markers? What can we use to measure our vitamin status, our electrolyte status, and the like? Well, we can do a general hemogram. One of the points that wasn't really emphasized is that many of these patients can have mixed nutritional anemias, so that they can be both iron deficient and B12 deficient, and when you look at the MCV in this group of patients, it'll be normocytic. So you still have to screen for your nutrient levels. We do total protein albumin and pre-albumin or RBP. We can screen calcium, phosphorus, and magnesium, our usual routine labs. And in cholestatic disease, we do look at Triene and Tetraene ratio. Now, trace element screening is problematic. There are many caveats because trace elements you're looking at a dynamic condition where trace elements are sort of freely fluxing from serum to other body stores. And the same thing with fat-soluble vitamins. They seem to be in a continuous state of flux. You haven't seen this slide yet. This is basically the half-life of our various proteins. So if you're looking at a patient in whom you suspect acute protein malnutrition, yes, a pre-albumin and RBP are helpful. But we don't routinely use them unless someone has an acute change in their nutritional status. And what about these mechanisms or what about these trace elements, and how do we measure those? Well, we can, again, tissue levels and serum levels don't always correlate with nutritional deficiency states. They're widely distributed. For example, when McLean documented zinc deficiency in liver patients, he looked at dark adaptation in adults. We see that some patients will have a hypermanganesemia in liver disease, and that may be because there's an enterohepatic circulation of manganese. Some patients are hypercupremic, and that may be just reduction in ceruloplasmin. These patients may just have increased free copper. And I guess the question is whether these oxidants are really damaging the liver. If you are in Denver, you really believe that those oxidants damage the liver. But, remember, we have lysosomes, and lysosomes are important detoxifying mechanisms. So if you have a lot of lysosomal copper, it may not be as harmful as we think. And in fact, Val, I think this was one of those abstracts that never made it to a manuscript. We described 4 children who were cholestatic, sent to us on no copper because of cholestasis, and they were also neutropenic and anemic, and people were speculating that they had portal hypertension. Well, they didn't have such portal hypertension. They actually all had copper deficiency, and we corrected that when we corrected their copper levels. What about carnitine? It's synthesized from lysine and methionine. I think it was probably overutilized in maybe the 70s and 80s, and in fact, recommendations have now been updated so that really, unless you have one of those rare disorders of carnitine metabolism, you don't need the kind of carnitine levels that we were giving, the 20 and 30 and 50 microgram levels. In very low birth weight prematures, it might be helpful, and during cholestasis, its synthesis may be inhibited. But I think before you decide that someone's carnitine deficient, get a carnitine profile and look at the acyl and free ratio. Well, what about MCTs versus long-chain triglycerides? There are some significant advantages to MCTs because they, under moderate intake, they bypass lymphatics. But Dave Sigalet did a great study when he was in Kansas City, where he overloaded patients with overloaded animals, animal studies with MCT, and found that significant quantities were actually absorbed through the lymphatics. And conversely, when he overloaded these animals with long-chain triglycerides, he found that there was some direct absorption into the portal circulation. The other advantage, even though medium-chain triglycerides are used for rapid energy mobilization, the energy can't be stored, so that these fatty acids may produce acidosis. There's a relatively high osmotic load and fewer kilocalories. Remember that the amount of calories generated by any fat is related to the chain length. So medium chains can provide as little as 6 kilocalories per gram. The longer chain triglycerides produce bowel adaptation, higher caloric density, and lower osmolality, but less effectively absorbed. So excessive medium chains can result in essential fatty acid deficiency, and we discovered that probably 20 years ago. So most formulas have been reformulated, even those that are used for patients with cholestatic liver disease, to have much less MCT than they used to. At most, they have around 55%, and some of them have as little as 30% MCT. The Triene to Tetraene ratio, is a ratio of the meat acid to the sum of arachidonic and linoleic acids, and they all compete for the same desaturases. And when the omega-3 and omega-6 are deficient, the meat acid is synthesized, and if you have a ratio of greater than 0.2, as Rob mentioned, you have EFA deficiency. What about water-soluble vitamins? Generally, patients are sufficient, but during shortages, as we see from time to time, deficiencies, when the patients are fed parenterally, deficiencies will appear. What about surrogate markers now? Again, a reduced alkaline phosphatase is a very good marker for zinc deficiency. And everyone knows the clinical pathologic entity where we commonly see zinc deficiency. Remember, copper and zinc share the same carrier protein across the gut. Well, if you have copper excess, for example, in Wilson's disease, you're very commonly zinc deficient, and you'll have a reduced alkaline phosphatase. Pyridoxine deficiency is frequently seen in acute malnutrition, and a reduced ALT level is very common in pyridoxine deficiency. And neutropenia is a very good marker for copper deficiency. So how should we monitor for these deficiencies? Well, you can look at hepatic concentrations for vitamin A, but nobody's going to biopsy just to get the hepatic concentration. You can measure you can do the measure retinol and do a relative dose response. You can do either an IV dose response or an oral dose response. And if you measure retinol at time 0 and then at 5 hours, and you have a greater than 20% rise, you'll have reduced stores. If you have less than 10%, you never have reduced stores. So between 10 and 20%, there is a gray area. Drew Ferenchek and Ron Sokol looked at the various tests that we do, and what they actually found, now they had 25 patients who were cholestatic and 10 patients who weren't. They had some liver samples, and they measured liver vitamin A. And when you correlate liver vitamin A with the RDR, there is a very high correlation, 100% specificity, about 80 to 5% sensitivity. But then when they compared RDR with a variety of markers, they actually found that retinol was really as good as the retinol RBP ratio. or much, much better than the touch cytology, looking for dry eye, slit lamp exams, tear film breakup, I don't know what that exam is, and the Schirmer test, looking for production of tears. We have to remember, though, that vitamin A goes back into the tissue stores very quickly as a stress response. All of the African studies suggesting that vitamin A deficiency might predispose to acute infection really have been debunked, because many of these children were acutely ill, had low vitamin A levels, and then when they recovered from their illness, their vitamin A levels spontaneously normalized. What about D status? Well, 25-hydroxy is the preferred metabolite to measure, and the reason we measure 25-hydroxy is because all of our stores are in 25-hydroxy. Even though 125 is the active form, it tells us nothing about the stores. We can measure PTH levels, and if they're elevated, that's very strong suggestion of vitamin D deficiency. And the TRP is a poor man's PTH level. If you're waiting for a week to get your PTH level back, and you're not supplementing with very high quantities of phosphate, you can measure tubular reabsorption, because one of the first things to become abnormal when you have a high PTH level is your TRP. So what you do then is you waste phosphate and retain calcium when you have hyperparathyroidism. So this formula, 1 minus the urine phosphate over the serum phosphate times the serum creatinine or urine creatinine times 100 will tell you what your TRP is. It should be about 100% if you have a low serum phosphorus, and it should be greater than 80% with normal phosphate. Ron Sokol, when he was in Cincinnati, did sural nerve biopsies in a group of patients and correlated vitamin E levels with abnormal sural nerve biopsies. What he showed was that serum vitamin E was pretty sensitive, but there was a handful of patients, 2 or 3 patients, who had normal vitamin E levels and an abnormal neurologic exam and sural nerve biopsy. What they then looked at was, because vitamin E is fat soluble, they looked at the total serum lipids. And when they did the vitamin E to total serum lipid level, they found that those patients who were missed by measuring just vitamin E were picked up. Now remember, you shouldn't just do triglyceride, because triglyceride varies with diet and fasting levels. There's a great deal of variability. Cholesterol, if you're going to use one fat, cholesterol is more reliable than serum triglycerides because of they vary greatly. Vitamin K, you can measure the level. Ideally, what you want to measure is the direct effect, and you can measure either a factor 7 level or a prothrombin time, and generally we just measure the prothrombin time. So how should we manage these kids? Finally, this is my last set of slides, or last few slides. We do not excessively restrict fluid and salt. We may use zinc supplementation orally. We strive for about 130 to 150% of the recommended daily allowance. And we really like to give nocturnal tube feedings or a late night snack to our patients. Protein should not be restricted. Remember that you should really give about 45 to 60% of the daily caloric distribution as carbohydrate to actually spare protein and suffer the DRI and satisfy the DRI. Some branch chains may improve nitrogen balance, but there are very few branch chain formulations available. There are branch chain formulas, quite expensive, and generally patients will do relatively well without getting branch chain amino acids. Fat, there's no rationale for restricting lipids, even if you have fat malabsorption. If you have total bile duct ligation, and disruption, you'll still absorb about 50% of your ingested fat. The MCT supplementation is advisable, but remember that you have to give essential fatty acids to prevent deficiency. There was an epidemic of fatty acid deficiency when people were using a formula that had something like 92% or 95% MCT and 5% LCT. You should supplement with varying levels of vitamin A, D, E, and K. And finally, in summary, indirect calorimetry is helpful. I would lobby for that, even if we have a moving target, so to speak. A patient with liver disease should not be deprived of calories or protein. Remember that our ammonia in hepatic encephalopathy, 95% of it comes from our glutamine stores. It's due to deamidation of glutamine. And there's normally a cycle, and it's usually a disruption of that cycle rather than exogenous protein that produces it. You should monitor the patients for signs of glucose intolerance, and I think it's wise to use a hemoglobin A1C in these patients. Nitrogen balance is better if branched-chain amino acids are used, but the question is whether that is clinically meaningful. And then end-stage benefits may benefit from nighttime feeds. We should supplement vitamins, and MCTs are important energy sources, but you should give EFAs.